could you just tell us, as they say, how it all panned out for you and where it all started?
Yeah, I had diabetes insipidus in my first two pregnancies. Oh, actually, all three pregnancies. I've got three little boys. And the first two times that I had diabetes insipidus during my pregnancy, it was undiagnosed. So basically, I went through the whole pregnancy both times without being medicated and without it being diagnosed. And it was only after delivery of Jackson, my first child, that I was diagnosed maybe about a week later. And with Bradley, I was diagnosed about 5 months after he was born.
So forgetting any medical words, just tell us in that first pregnancy. So prior to your first pregnancy, you'd been completely healthy. Is that right? No medical problems. So
oh no, well, no, I have an underactive thyroid. That's about it.
Okay. And that's ever since sort of what, teenage years or underactive thyroid?
I think I was about 22, 23 when I was diagnosed with that, yeah.
Which is interesting because that's an autoimmune condition. So just tell us how things, but you got pregnant, and just tell us when things first started to go wrong during that first pregnancy. What symptoms did you have? What was the first thing you noticed?
To be honest, for me, it's all a bit of a blur, because when it's your first pregnancy, you don't know the difference. You've never been pregnant before, so you don't know what to expect, what's right, what's not right. You know, I also had an awful lot of morning sickness. I mean, I still don't fully know whether that was to do with any of it. Yes, I was drinking an awful lot. I had really low blood pressure. I just didn't really bode well being pregnant, full stop. I think I actually went from 11 stone to 7.5 stone pregnant before I actually delivered Jackson. So ultimately, I think there was a couple of warning signs, but yeah, I had no idea. And we had no idea the whole time I was pregnant. I went in, basically, I'd been going in and out of hospital the whole time. I was in and out of labor from about 20 weeks. It was good that I even managed to get to 37 weeks with Jackson, my first. And I remember feeling incredibly unwell, went into the hospital in labor. They took some blood, sent me home. And then I had a phone call whilst I was doing a food shop with my mum to basically say, your bloods aren't good. Can you come in straight away? You need to have this baby. Came in, had a baby.
Can you remember, was that because your liver function was very abnormal? Can you remember why they called you?
Yeah, it was. Yeah, right. It was. And I think my sodium levels were not great.
Right.
My LFTs were massively raised, all those kind of things. Is it your unis or something like that? So yeah, there was a lot of alarm bells, but nobody knew what was going on or what any of it meant.
So it sounds, so this is a rare situation, but it sounds like you were non-specifically unwell, and then you were very dehydrated with abnormal liver function, and very rarely with liver disease in pregnancy you can get diabetes insipidus for reasons we might be able to discuss. But it's, and then I think you had quite a stormy course, didn't you, when you were admitted to hospital in terms of your other organs and things?
I mean, yeah, actually, I couldn't have been dehydrated because I was constantly over drinking, in effect, because when I was actually delivering Jackson, I drank, I think it was like 15 litres whilst in labour. So amazing. Ultimately, I was probably drowning myself from the inside out, not really realising that's what I was doing. And then after I had Jackson, I delivered, they took me onto the maternity ward, and I remember standing up, going to the bathroom, and it all just going horrendously wrong. And my heart, liver and kidneys sort of failed, and I was in intensive care and blanked. I don't really remember much of it. And from that day, I have very much no memory, really. And they used to sort of bring me Jackson and say, you know, here's your baby. Does he have any hair? Take him away. And I'd, you know, not have a clue, and actually have a full head of hair. So it was crazy that I wouldn't even remember that. I wasn't really speaking. I wasn't able to watch TV. I wasn't able to really sort of do much at all. I do have one memory, and that was being taken back onto the labour ward, because ultimately I couldn't go to intensive care. So they had to put me in labour ward with somebody 24/7. And I remember waking up in the middle of the night, realising that I wasn't pregnant anymore because I didn't have a bump, looking to the right-hand side, and the cot was empty, and just screaming, thinking, where is my baby? I didn't remember delivering. I didn't remember anything. And all had happened is they'd just sort of taken Jackson away to feed him. But I didn't remember. And it was probably the most scariest thing to date for me. But
so you were really unwell. And in fact, you nearly died, it sounds like, during pregnancy. So you're both lucky in a way to be alive. And then presumably you recovered. Did you manage to breastfeed, by the way, in that pregnancy afterwards, Jackson?
I breastfed all 3 of my children.
So that's a very good sign that your pituitary gland is working normally, because prolactin is the milk producing hormone. Then tell us about and then in between that, what was the gap between that and your second pregnancy?
There's 14 months between my first and my second. So I think I was about 6 months in, and then fell pregnant with Bradley.
And between the two pregnancies, were you okay, or did you take a bit of a battering in? Because I know you said you had a bit of a break, your sodium levels would have shifted dramatically, so that might be the reason why you had those, the cognitive or the difficulties remembering and recognizing things, because the brain swells massively when the sodium's low, and it shrinks, as we can talk about later on. So tell us about the second pregnancy. What happened? Do you remember much about that? Because presumably your obstetricians were a little bit, if you were in the same region, would have been a bit on alert, or so what happened?
There's nothing. I went undiagnosed again for the second time.
Tell us what happened. Tell us what happened in the second pregnancy and when problems started then.
I think they would have started quite early on, and I knew I was over drinking, and I was saying, I think, but ultimately I didn't realize, but you can also self-level, apparently. So I believe I was self-leveling.
What do you mean by that? You mean drinking?
I don't know. I spoke to another specialist, and they said to me that you can actually self-level. So actually you can overdrink, but almost try and self-level yourself. Your body can be quite clever about self-leveling. But to be honest, I think the whole thing is still so much of a roller coaster for me that I'm still on a pathway of discovery and finding out exactly what happened, all of it really.
Yeah. But in that second pregnancy, you were drinking because you were very thirsty. Is that right? I mean, it sounds like
absolutely. I had diabetes again.
Yeah, but the symptoms, whatever it's called, the symptoms were that of extreme thirst. And did that happen at the beginning of pregnancy or towards the middle and end?
I think, see, here's half my issues as well. I have terrible memory loss.
Yeah.
So I'm pretty sure I was drinking quite early on with Bradley. With Jaden, I was drinking, but it was a little bit later on.
And it sounds like a stupid question, because if you drink a lot, you wee a lot. But do you remember very excessive urine output during that time?
Yes.
And were you getting up at night to pee?
Yes. But again, you can, I was always told, it's very unlikely that it would ever happen the second time around. So you kind of sort of say to yourself, don't be silly. You're being, you're in your own head. You're thinking this is happening and it's not happening. People are checking you out. It's all fine. And ultimately, it wasn't fine.
And just in terms of the increased thirst and the increased weeing, when you weren't pregnant, I know everything wasn't perfect and not quite right, but did those specific symptoms of being thirsty and weeing, did they settle down in between when you weren't pregnant, sort of thing? Or were they better?
They probably improve slightly. Yeah, they probably do improve. Yeah, nowhere near as much. Yes.
Yeah, but still not perfect.
But I definitely still, to this very day, drink an awful lot more than what I ever used to.
Right.
And, even the thought now of being on an hour and a half call and not having water at the ready, before any of this, there wouldn't have been a second thought about it. I'd have just gone and taken them. But it's like, there is no way. And there's always some in my car, somewhere, because it will just hit you like a
when we chatted a few days ago, I felt that, probably we needed to investigate you and see you, because it didn't sound purely like it was related to pregnancy. So we might
I mean, I've been told that it's all been adjusted and I'm absolutely fine now, and it was only during pregnancy, whereas I would probably suggest that I still overdrink.
Yeah, yeah. I can see something flashed up from Eleanor saying, "Are you not medicated?" So on desmopressin. So I think you're not on any desmopressin. And the important thing, Eleanor, I mean, I've not seen Ashley in a medical capacity. You live in Jersey, but it's very important to make sure you do have diabetes insipidus before we give you any treatment, because if you do have what's called primary polydipsia, we run the risk of over diluting your blood and giving you serious problems with low sodium and seizures. So definitely we need to have a think about how to investigate, which we could talk about. And so how did the end of that second pregnancy go? Did that wasn't as dramatic as Jackson, was it? Or
it wasn't as well, it still wasn't good, and I still had issues. But I also managed to pick up norovirus after having Bradley as well. So that put me straight back into hospital within a day as well.
okay.
So I think I've been quite unfortunate that there's been a lot of other things happening at the same time. So it's always quite easy to blame something else. You know, after Bradley, I had almost, septicemia, where you have a really, really bad infection, where I was nearly put back into hospital with that.
Oh.
I also passed kidney stones from obviously being over dehydrated, and then found out I had horseshoe kidney. And since then, it really has just been a spiral of number of things being found out. Since.
So I can see a question came up from Ruth asking if you'd had a water deprivation test, which is a very good question, because that is a way of diagnosing diabetes insipidus, hopefully soon to be absolutely old-fashioned. And I think Pat McBride tells a good story about how terrible water deprivation tests are if you truly have diabetes insipidus or vasopressin deficiency. So we'll come on to that, Ruth. Thanks for the question. So right,
The answer is no. I've never had one.
No, well, hopefully we'll spare you that if you come and see me in clinic, because there are cleverer ways of measuring it these days, of making the diagnosis. But so you had your second child, and then it sounds like the penny dropped, if you excuse the analogy to spending a penny, with diabetes insipidus in your third pregnancy. So what happened? Just tell us how that came about and whether that made it better or worse, or
so with Jaden, I was like set on, I'm all over this and I will fight this to the bitter end. If someone tells me I don't have diabetes insipidus, and if I believe I do, I'm going to push and push and push and push.
So what made you eventually, did you Google it, or what made you come to that conclusion? When you say, is that because you did your own research into it?
No. So after Jackson, I was told I had diabetes insipidus a week after having him.
Right.
So what I'm saying is it never got picked up during pregnancy, but was diagnosed thereafter. What happened with Bradley is I was having so many other issues, kidney issues, all this kind of stuff.
So got neglected.
And I went back to see the endocrinologist, the very, very intelligent specialist doctor over here in Jersey. And he then looked at my results and looked at everything else and looked at my history, and then went, "Oh, what happened to you a year ago, September?" And I went, "Oh, I had my second child." And he was like, "Ashley, you had diabetes insipidus again." Right. So only was it after that massive period of time did he then look back at my case and go, "Wait, that you had it again." And then I told him, I'm now pregnant with a third, and he was like, and then that was it. He wasn't on board in my care and everything else. And then I said to him, "I'm telling you, I've got it again now." But it lasted a lot longer later down the line with Jaden. I actually thought potentially I was having a girl and not a boy, and I thought, maybe it's connected to a boy, not a girl. And I thought, maybe I'm having a girl, and actually I've got away with this. And I was really kind of happy that I'd managed to not get it a third time. And then it turns out that I did actually have it, and that was quite hard to take at the time. And that's what was actually on the show, was me getting the news that I actually did have it again. And
I see. So it was on so diabetes insipidus has made it on global TV. So what stage of pregnancy did you get those symptoms?
I actually think I had the symptoms a little while before I had the diagnosis with Jaden. I was definitely in my second trimester when I got it with Jaden.
And were you given?
But I do remember getting it earlier with the other two, which is another reason why I thought, I've got away with this, and it turns out I hadn't.
And were you given any treatment, desmopressin treatment during that third pregnancy? And did that give you an easier ride? How was that?
Massive difference during pregnancy and a huge difference in my recovery thereafter. You know, all my family always said to me, like, oh God, Ashley, like, look at the difference in you now that you've had Jaden. I was actually upright and I was doing so much better. And I actually do remember delivering Jaden, whereas I don't actually remember giving birth to any of my other older two. And so I remember some of the experiences, which I never remembered with the other two.
So that's massively important. When you make the diagnosis, you can have much safer. It sounds like you almost crash landed in your first pregnancy. I could just see a text or a message from whatever you call it, from Lisa, saying she's glad that there are alternatives to the water deprivation test. She's had two, one when she was 4, and you hear, and also another one when she was 7, and you hear stories of children licking the condensation off of windows and trying to drink out of toilets. So if you do the water deprivation test properly, you actually take the taps away from the sink. So it's actually quite barbaric. It's almost like sort of the opposite of waterboarding. So thanks for that, Lisa. So Ashley, since pregnancy, it sounds like you've still got some need to have a bottle of water nearby. And do you also have the same issue in terms of needing to have a toilet nearby if you're in a long car journey or getting up at night to pee? Or not?
You know, yes, yeah, you do. And it could wake me up at night, but also having basically drunk far too much during my other pregnancies, I've actually managed to stretch my bladder.
Right.
So my bladder capacity actually got far beyond, and that started then causing other issues. So I think I've managed to train my bladder and bring it back down. But also I had major problems with needing to go to the toilet and actually my brain not knowing that I needed to.
Yeah.
So that was diagnosed, the connectivity between my brain and my bladder, there was just no electrode saying you need the toilet, you need to go. There was nothing. There was no signals of like, oh, I actually need the toilet. Like there was, my brain just didn't seem to compute with my body.
Amazing. And we've got a message from C. Michaels to say that C. Michaels, I don't know, I'm afraid what gender, lost so much weight during water deprivation that it had to be stopped in case my heart was affected. So that one of the reasons one stops the water deprivation test is you can lose so much water that you lose a dangerous amount of weight, and that absolutely can be hazardous all around. So listen,
Gosh,
Ashley,
that's a brilliant. This actually happens.
Yeah, well, we can explain what the new advances are. And actually, that was amazing, a brilliant start. So stay on the line. If you don't mind, what I'll do is I'll talk about what it was that made you thirsty and what if we can get the slides up, and then I'm completely happy to stop if I'm getting boring and a bit too sort of scientific. But if we can go to the next slide, what Ashley is describing is an abnormal regulation of water, and with that comes salt. So sodium levels are really a product of what's happening with your water. So if you've got too much water in the blood, the sodium goes low, and if you've got too little water in the system, the sodium goes high. And there's a vital part of the brain that beautifully controls salt and water called the hypothalamus, that sits above the pituitary gland. It's just above that red dot, which is the pituitary. So it's the hypothalamus, so-called supraoptic nucleus. And what that does is it tells you exactly how dehydrated you are, or whether you've got too much fluid on board, and therefore controls how much water you should drink and how much water you should pee. So if we go to the next slide, I'll take you through that very slowly. So this part of the brain senses dehydration, and the medical word for that is osmolality. But basically, the higher the concentration, a bit like how if you drink orange barley water or Ribena, if it goes darker, that's high concentration. Of course, if it goes paler, then it's low. And so the hypothalamus senses whether your blood is too pale or too dark, if you want to use that analogy. So if we carry on, next slide. So when Ashley was very, very dehydrated in pregnancy, and I think her clever endocrinologist from Jersey probably picked up that she had a very high sodium level, which is a marker of dehydration. What her brain was saying was two things. Firstly, you need to drink. And so the thirst mechanism is a life-saving mechanism. It's very conserved in evolution. So all animals get thirsty because there's only two ways of conserving water. One is to chuck water down into your body to drink, and the other one is to stop peeing. Now, stopping peeing is a very, very important thing that's controlled by a hormone that used to be called antidiuretic hormone, or ADH. So it does the opposite. You all know that diuretics make you wee. So antidiuretic stops you weeing. So the modern term really is vasopressin, or AVP, arginine vasopressin, because things are known a bit more about the gene that causes it. So in the normal situation, when you're dehydrated, you drink and you get thirsty and you stop peeing. But unfortunately, if you're not producing vasopressin, as Ashley probably wasn't in pregnancy, and very interesting, actually, pregnancy is associated with a condition where you break down. So she was probably producing just about enough vasopressin, but her pregnancy was breaking down that hormone, so it wasn't working. There's an enzyme called vasopressinase. And actually, interestingly, it can be associated with something called acute fatty liver disease of pregnancy. So I think actually in that first pregnancy, you were really unwell with either preeclampsia, eclampsia, or something called acute fatty liver disease of pregnancy, where you can get multi-organ failure. And I think that's the reason that you got diabetes insipidus, was because you weren't breaking down you were breaking down that hormone excessively and it wasn't working. So it was a byproduct.
I tested for preeclampsia and I didn't have that.
No. So you probably had acute fatty liver disease of pregnancy, which is on a similar spectrum, but you didn't have the high blood pressure and the proteinuria, possibly because you were so unwell, you see. So it's a very unusual situation you're in, but normally one would produce vasopressin. So if we just go to the next slide, if I can see whether that makes it more simple. So the way vasopressin works, or antidiuretic hormone, or AVP, it works like a plug in a sink. So if you press the next button, you'll see that if you imagine what's in your circulation is like the water in a sink. So when you're drinking, imagine that's turning the tap on. If you don't produce vasopressin, then all the water goes down the plug. Okay, so if you press the next button, vasopressin is the plug. So what that does is it stops water going through the urine. So if you press the next button, it puts in the plug, next button. So what happens is when you're dehydrated, when the body senses it needs to conserve water, the plug goes in. That means you're producing vasopressin. You're turning the taps on, which means you're drinking. And because you're reabsorbing water in the normal situation when you're dehydrated, that's when you stop peeing and your urine looks dark. So if we go to the next slide, when someone's dehydrated, it's probably easier for a man than a woman to say this because of the anatomy. You can see what you're weeing when you're a man, probably easier than looking into the toilet. But when you are dehydrated, done a lot of exercise, and when the body's working normally, the reason your wee looks dark like that is because your body is conserving water and getting you to pee out as little water as possible. And that is the vital life-saving role of vasopressin. Now, when you haven't got vasopressin that's working because of a condition, either because of Ashley conditions happening associated with pregnancy, or because of the pituitary gland problem, which I would imagine the majority of people on this call have got. We go to the next slide. So that's the concentrated urine as a result of normal dehydration. So next slide. When there's no plug, in other words, when you can't produce vasopressin, there are some conditions where genetically you're never born with vasopressin. There are some conditions where you have a pituitary tumor, or you might never have produced vasopressin, or there are some situations where you don't see vasopressin because of the receptor. Suffice it to say, when there is no plug, if you go to the next button, what happens is because the plug, next button, is not working, next button, then what happens is it all comes down the plug hole, if you next button, and therefore you just pee gallons of pale water because you cannot conserve it, and therefore you're hosing out very large quantities of urine that do not look pale. So don't press a button yet. So even if you no, keep going, you're all right, go back to where we were. That's it. So even if you were in the Sahara Desert and you were running around doing a marathon, you would desperately need to pass no quantities of very dark urine. If you have diabetes insipidus or vasopressin deficiency, even in that extreme situation, you would still pee gallons of water. And that is why C. Michael, who gave us his text to say when he was having his water deprivation test, he lost a huge amount of weight. He could not hang on to any urine and therefore lost a dangerous amount of fluid. And when your weight fluctuates with diabetes insipidus, it is because of the water, not because you're getting fat or thin. It's because you're losing or gaining huge amounts of water. So
sorry, can I also ask Miles, just to interject that?
Yeah.
So I still have days where my weight seems to fluctuate on a daily basis, but to extremes. You know, 1 minute my wedding band literally falls off my finger, and then later on I cannot get it off, and it's almost cutting the circulation off my finger.
Yeah.
So is this to do with this? Is this to do with this? Because this still happens even now.
It might be, but the thing that you're a little bit more unusual, I think, because the thing that you're describing, I think that, you know, we need to seriously think about whether you've got autoimmune disease because you've got hypothyroidism, and the fact that there is a rare condition in pregnancy called lymphocytic hypophysitis, which is a condition where you get diabetes in pregnancy. So I think in your case, I think one would need to do a lot of tests. You don't classically get swelling of the hands, but certainly you can get major fluctuations in weight. Now, just seeing in the chat, SL has said, before SL found out he or she had DI, they had to do a water deprivation test by stopping drinking for 8 hours. I had no idea I had DI, but after the test, got a call sent to hospital. The hospital never had a case before. After the test, I was so dehydrated, I was really unwell and didn't know what was happening. So I think we're getting a bit of a picture that they're pretty unpopular, these water deprivation tests. So Ashley, if you came to see me, we would try and avoid doing one of those. But yeah, I mean, there is a rare condition actually called adipsic diabetes insipidus, where people don't have a thirst sensation, which is an absolute nightmare because patients don't know whether they need to drink or not. And the only way of knowing what to do is by weighing the patient daily, because if they put on weight, you assume that they've had too much water. And so that is associated with really difficult, it's a difficult thing to measure. And actually, through all this one of the beauties of talking to patients is we've spoken to Pat Gilroy, who works with the American group called Got DI, and she has a patient who's managed to work out a way of measuring sodium through a finger prick test, not through a blood test. So we're working with them, with the great and the good, to try and work out sort of immediate ways of being able to test sodium in this condition. Ruth is explaining to everyone, Pat and Pauline said about the sink and, all right, thank you. I was just saying that the sink analogy is helpful. So if we can go to the next slide to see where I am.
Miles, Miles,
yeah.
Could I just, there's a message Pat on there from Giulietta.
Yes, please do.
So she asks, can I ask if this gestational DI comes under the hat of cerebrally generated or nephrogenically generated, and why?
Yeah, so there's if that's Giulietta Horner, who by the way I've been chatting to because she has had a terrible experience. Her brother, who was in his 40s, died of diabetes insipidus, and she's happy to go on public record to talk about that. So I'm really grateful for people that have had bad experiences to share them. So so the answer to your question, Giulietta, and you might want to tell us about your experience with Charlie whenever you I'm sure we'll have the chance because we've still got 50 minutes to go. The answer is typically in pregnancy, it's cranial. In other words, it's the pituitary gland that's not producing enough, so called AVP deficiency. There are a few situations where you can get the nephrogenic form, but pretty much it's either due to deficiency of the hormone or because you're breaking up the hormone too much because of the enzyme produced by the placenta, which is the same thing as not having enough. So the treatment, desmopressin, should work. Whereas if it's a renal, the desmopressin won't work, which again, we could potentially talk about, but it's a good question. I mean, Giulietta, I don't know whether you want to interject now about Charlie or whether you want to wait till the end. Pat, you're the boss.
No, if Giulietta wants to talk, that's fine.
Why don't you unmute yourself? Because otherwise it's just me talking, Julietta, and then we
Sorry,
can
I was
we
just
can
trying to
revert
put out,
back.
sorry. Well, just to tell the story of Charlie briefly, he was quite a bit, four of us, quite a bit younger than the rest of us, and when he was 15, got a brain tumor, and wasn't quite a serious kind of brain tumor, and they couldn't operate on it. But in the course of the surgery in those days, which was a lot more basic in the 1980s, they knocked out his hypothalamus and his pituitary gland, and he was put on to desmopressin, which in the early days it was up the nose, nasal stuff, wasn't it, all the time, Miles, I think, and then he was so relieved when he could have it other ways. Anyway, long story short, he had one or two ailments over the years, but sort of got through, and then he got low sodium and went into hospital with this low sodium, and the clear instructions, they managed him pretty well during the week, but the clear instructions were if he peed out a certain, I think it was 100 mils of water, then it would trigger a dose of desmopressin. So his sodium level went up enough, and then just suddenly it just seemed like everybody forgot or didn't read the instructions. Everybody forgot why he was there, and nobody measured the fluids, nobody gave him any desmopressin, and I was there one day saying goodbye to him, have a good night, I'm off to a party, see you in the morning. And we'd all gone in the morning, the whole family, to because we were going to tell my mother. She wasn't really coping so well with having it at home. My sister and I were going to have him to live with us, really. And we'd all got phone calls saying he'd been found in a coma. But nobody really said that they weren't expecting him to live. So everybody else, except for me, went home in the afternoon. And suddenly, in the early evening, he just, that's it, lights out, he went. And it was that his sodium had rocketed to this level of 188, which is the normal standard levels should be between 135 and 145 mils, isn't it, Miles? And yeah. Charlie's had got so high. So that's when you're talking about the brain shrinking. We think his brain had shrunk and he'd gone into coma, and I will never know what happened over that night. But I knew, because of the other medication he was on, I knew it had to be to do with the DI and the endocrine system. So I went from there. So that's the basis of the story.
It's a terrible story, and unfortunately you're not alone. And I know that you're trying hard to put things right, and you've got the details from the coroner's inquest, and I know that you wanted to chat with Rita Cronin, who I spent, one of the reasons that we've been on a campaign for this, and one of the reasons why I'm talking to you today probably is just before lockdown a few years ago, an endocrinologist from Croydon in South London contacted me because I think Malcolm Prentice, he knew that I was somehow interested in pituitary disease and this. I can't remember why he rang me actually, but he told this terrible story about Kane Gorney, who had a benign tumour and was admitted over a bank holiday weekend to a South London hospital for a routine procedure and ended up dying with a sodium of 191. And he actually rung
the police
999 from the hospital bed because he said he was dying of thirst. So and the reason being that people, in fact, I don't know his sodium was 191. That's a patient we had at Leicester with a similar problem. And but the reason being that the nurses on the ward thought he had sugar diabetes. So the term diabetes is incredibly off-putting and unhelpful because you're just going to get your blood sugar measured. And we've just published a paper in the Lancet, which is a good journal, with the help of Miriam Chris Crane, who's the doyen of vasopressin. She's a Swiss person, as well as with Jova Bayliss. And 85% of patients of 1,034 patients said that they had confusion with diabetes and they thought the name should be changed. So if we can go to the next slide, I'm gonna sort of keep talking, and then we can do the sort of interactive session from about 8 o'clock. So keep going. So diabetes insipidus is where you haven't got this plug and you're hosing out fluid, and that's what was happening with Charlie that night. The reason his sodium went up to 188 is because he was losing water, and he needed water to be given back, and he needed desmopressin to put the plug in, and he wasn't. So he was basically dying of dehydration on a ward, as has happened not because nurses and doctors are trying to kill anyone off. It's just because there's an education gap. And part of this is PR and how this is branded as a condition. So Kim, if we could have the next slide. Diabetes insipidus, the diagnosis is made by the passing of huge quantities of pale urine that looks indistinguishable from water. It's associated with an extreme and unquenchable thirst, not just for water, but also for cold water. And I think I remember, Pat, we did a podcast with the B&J and you very eloquently describing what it's like having this condition. It's like eating sort of salty bacon sandwiches with chocolate, well, not chocolate, with digestives, you know, without any water. And so at best, this is a very unpleasant condition, and at worst, it's life-threatening. And one of the problems is, as you're beginning to see, is that it's not very well understood by the medical profession, probably because it is a rare condition. It affects about 1 in 25,000 people, which is a rare condition. Yet diabetes mellitus, sugar diabetes, everyone's got it. And just to let you know that diabetes, the word is the Greek word for siphon, which is some weird old-fashioned machine that water goes in and water goes out. So diabetes is the clinical description of someone who is thirsty and wheeze a lot. And there's two forms of that. One is because you're losing water, which is what we've described. But the other cause is that the sugar level, glucose, is very high and it's pulling the urine out. So the way hundreds of years ago people used to, and no one had type 2 diabetes hundreds of years ago because no one was obese. So malnutrition in the old days meant you were skinny, whereas malnutrition and neglect these days is having an obese child because you're eating burgers and crisps and sugary drinks. And so no one had type 2 diabetes. And what they used to do is put the urine on the floor and put insects down. And if the insects crawled towards the urine, it was sugar diabetes. And if they crawled away from the urine, it was insipid, uninteresting. And that's where the name came from. And unfortunately, the name has persisted, but it's not really fit for purpose in 2022, 2023, because type 2 diabetes is what all the healthcare people will think when you say to them, you have diabetes insipidus, they'll think you have sugar diabetes. So next slide, please. So, and as we're talking about with Charlie and with Kane and maybe probably I think maybe even Ashley when she was towards the end of pregnancy, and the reason why I think you've had some problems with your memory and, you know, facial recognition is I think probably, I can't tell you this, but what probably happened is you had very major shifts in sodium. It was probably very, very high when you were called by your doctor to come in when you were shopping with your mum. And then when you were delivering and you had 14 litres of fluid, it probably went from very high to very low. And the brain does not like big shifts in sodium. So if you can click on the next thing, Kim, if that's a normal sized brain, when you lose fluid, keep clicking. When you lose too much fluid, it basically turns into a walnut, not literally, but it goes very, very small. And the brain is within a bony cage, the skull. And so it rips away at the vessels and you can have an intracranial catastrophe. And that is almost certainly what happened to Charlie and Kane. They probably died of an intracranial disaster, and that's why they went into a coma. And equally, if you go the other way, if you have too much fluid, and one of the reasons why we wouldn't want Ashley to have desmopressin until we know she's got diabetes insipidus is because if she has fluids and desmopressin, the brain could swell, and that can cause cerebral edema. That can also cause a coma. So you don't want it. You want the brain to be a normal size. So it's very important to treat the brain with kid gloves. So too much sodium, the brain shrinks with too little water. Too much water with too little sodium, the brain swells. So the next slide, if that's okay. And the reason why Kane was ringing 999 from a hospital bed was that his sodium was so high that hypothalamus, that slide I showed you first of all above the red dot, his brain was saying, I am desperately in need of turning the taps on to drink. Otherwise, I'm going to die of dehydration. And that is an incredibly agitated state. And in fact, when we admit patients to hospital, when I'm on the wards and I admit very, very elderly patients with a high sodium, if they are not desperately trying to climb out of their bed for a drink, that is a really bad sign that they might not survive. And the commonest reason for seeing a high sodium in our hospital is patients with dementia who are completely obtunded, who can't, pull it out of the bag to drink. So Kane had that one chance he was actually trying to climb out of bed. He'd had a hip replacement and he was trying to climb out of bed, but because he was a young guy, people thought he was coming off drugs, but he was just desperate to drink. And so then what happened was he slipped into drowsiness and coma because his brain had gone small, and probably the same with Charlie. And if not treated, that is a fatal condition. And I did a survey, we did a survey for the whole of the UK, and they are not isolated cases. Next slide, please, Kim. So this is the headline. It made its way into Daily Mail. It made its way. In fact, Rita was on the TV. So for what happened was she couldn't speak about this. This happened in 2008, and I rang her. We had a 2-hour conversation about it actually, and I was my jaw was sort of, pretty dropped when I was speaking. And this was 2019 we spoke about it, so 10 or 11 years later. So she was only just able to talk about it. Her daughter had a nervous breakdown, her son, it's caused huge problems. But the reason that she went to the press about maybe 5-10 years later was if you remember the case of Mid Staffs, it was a hospital that was pilloried for not doing basic care for patients. It was on Panorama, and she saw a clip of an elderly patient who was drinking water from a vase, from a flower pot, because she wasn't getting the basics of water. And it reminded her of Cain when he was desperately thirsty. And because she'd sort of got over it and could speak, or not got over it, because she was able to be more functional, she rang the press. And that was when this sort of got into the public media. So it was some years later that it became recognized. And she's really keen to continue to help. And I'm pleased to say that we've made quite a lot of progress since that time. Just as amusing aside, what I see also on that Daily Mail is that Prince Andrew was already in a bit of trouble back then, so some things never change. But anyway, so if we go to the next slide. Right, so here's the crux really, and this is why we've now got global approval from, I'm really proud to say that it started in South London and with us in the UK, and we've led the way because we've got approval from the whole of the UK, the whole of Europe, the whole of America, the whole of Australia, the whole of South America, the whole of Japan and Southeast Asia to change the name. So this is really cool. And it's been a brilliant example of how medics and by the way, with great help from the Pituitary Foundation and pituitary patients around the world. And it's an example of how we can put the politicians to shame, because we're basically doing this without any interfering bureaucracy. So this has happened, these tragic cases, because diabetes, as we've said, is an unhelpful and ungood term. And there's a massive lack of knowledge about this quite rare condition that you're all ringing in to hear about. And the tragedy is that it's completely easy to treat. So next, can we change the name to New Zealand? Yes, we will be able to. I gave a talk to the New Zealand Endocrine Society, Sharon, so you're pushing through an open door. I think Australasia and New Zealand are one and the same. So next slide, please. So all Cain and Charlie needed were fluids and desmopressin. So again, to use the analogy, if you click on a button, they needed fluids through the vein if you're unconscious because you can't drink. So they needed to turn the tap on, and a doctor or a nurse needed to give the plug. Next slide. And therefore, the patient would have reabsorbed water, stop peeing, and in the right environment, which would have been a high dependency ITU environment, probably would have survived. Okay, so it's very difficult to generalize because I can't, if you're not there at the time with Charlie and Cain, but it does sound like certainly we could have done better as a medical profession, and we've let people down, and that's why we're doing this. So next slide, please. So what can we do? So we heard about Cain and Charlie's case and thought, well, we can't just sit on our hands. So we've done several things. I mean, it's a bit of a land, sea and air thing. One thing will not work in a complicated healthcare system like the NHS and around the world. So we thought, well, the name diabetes is unhelpful. So we've decided to change the name. Now, there's no perfect name. Malcolm wanted to call it Pituitary Insipidus, but not everybody with AVP deficiency have pituitary disease. Some people thought about ADH deficiency because it used to be called antidiuretic hormone, but that abbreviates to ADHD, which has a different connotation. Vasopressin deficiency, unfortunately, abbreviates to VD, and a certain generation that means venereal disease. So what I can say is that AVP is the gene that produces vasopressin, and it's in all the textbooks. And when we suggested this name to the two main players around the world, Joe Verbalis in America and Miriam Chris Crane, they were pretty excited that if you talk about AVP deficiency and AVP resistance, it completely describes what the treatment is and what the cause is. And it also sounds pretty rare. So if you turn up to A&E to talk to your local A&E doctor or your GP saying you've got AVP deficiency, hopefully the first thing they will do is say, what on earth is that? I think I need to speak to an endocrinologist. And if that happens, and it sounds like you're deficient in AVP, because desmopressin, the medics call it DDAVP. So it sounds like you need something with the letters AVP in. So it indicates the cause and the treatment. So, you know, it may be the world takes a little bit of adjustment, but we are that is the proposed name change. What we definitely need to do with your help is increase awareness of the condition around the world. That's to patients, to members of the public, to doctors and nurses. And what we've managed to do, and I'm very proud of this, there's a thing in the NHS called the NCPOD inquiry. It stands for the National Confidential Inquiry for Perioperative Deaths. And it was previously so that you wouldn't sort of get the wrong arm chopped off or have the wrong kidney taken out. But we've managed to get salt and water approved as the best topic from the chief executive of this committee for next year. So hydration. So hopefully the days of people drinking out of vases will be over next, you know, if we can do this properly, because this is not just for you with diabetes insipidus. This is for patients with dehydration in the round, and many patients in hospital are dehydrated and deserve care. And we're also ensuring that desmopressin is what's called a critical medicine. So when it's prescribed, it has to be given. And we're starting a national registry, so we know everybody that's on desmopressin. So next slide. I've nearly finished, so we can have an interactive chat. Yeah, so we've been busy, and I spoke to Rita Cronin, Kane's mum, a couple of weeks ago, and I'd forgotten how much we'd achieved actually. And she seemed genuinely blown away by what we've done. I have no idea whether I sort of feel bad because every time I ring her, I've only spoken to her 2 or 3 times, but I feel like I'm reminding her of a bad time. But I think she probably wants a legacy to try and change this. And I think, Giulietta, you probably want the same thing for Charlie. So as long as we're not badgering people and unearthing sort of horrible memories, we really need your help, both for patients who've had good and bad experiences. So I told Rita that we'd had approval around the world for name change since we last spoke. I told her that we'd got the NCPOD inquiry to look at hydration. And I've started to be contacted by pituitary groups around the world. I spoke to a group called WAPO a couple of days ago, who's the World Association for Pituitary Disease, which is the sort of the non-UK pituitary, and the Pituitary Foundation have been brilliant and always have been. And through a contact, we've also got a PR guru who is probably on National Water Day, to make this all sort of line up nicely, is probably in March 2023. We're planning some kind of public media campaign for TV, radio. And to be honest, Ashley, if you're on board, given that you are a sort of, you know, a media star, any help that you can give or anyone else on this call can give to raise awareness would be amazing, actually, because we're all going in the same direction. Next slide, that might be it, actually. Mm-hmm. Yeah. So we need your help, and anybody that wants to email me, you're absolutely welcome to. Now I've got a few slides tucked away if there are any specific questions that make points, but otherwise I think maybe we should stop the sharing, and I'm very happy to take questions. And remember, you are all experts in your condition, so I've got just as much to learn from you as you have from me. So Pat, over to you.
Okay, so will my medical records be changed to the new name?
Yeah, so how do you change the name of a condition? You can't just say we want to call it that, although actually I've started calling it AVP deficiency resistance, as have a lot of medics around the country. But the way the boring world works is when your doctor puts a condition into the computer, it has to have a recognized, it's called a read code. And so we've managed to find a brilliant contact from this department who is going to change the code in 32 countries in the world, and he's joined our little sort of group. And so we're not going to completely get rid of the name diabetes insipidus in case we sort of alienate people. So anybody could, when the name is approved formally, any doctor can cause, there are loads of different names for many conditions. So for example, a heart attack is the same as ischemic heart disease, which is the same as coronary artery disease, which is the same as acute myocardial ischemia. So doctors are very used to using different names for the same condition. And so to start off with, AVP deficiency and AVP resistance will be a synonym. In other words, you can use that name if you want. And I would suggest that all patients and endocrinologists use the name they feel most comfortable with. I'm fairly certain that this will gain traction, or whatever the annoying word is, so that eventually the parent name of diabetes insipidus will probably drop. And there is precedent to this. So for example, the rheumatologists, they used to manage a condition called Wegener's granulomatosis, and they stopped that name because Wegener was a Nazi and they didn't want to name a condition after a horrible person. And there are a couple of examples of name change of condition for different reasons. And we've been told by the SNOMED CT, CD and the ICD-11 classification system that we've got a really brilliant, probably one of the best cases for name change and a brilliant alternative. So it seems to, so yes, you will be able to call it that condition, but all in good times. We'll probably change the textbooks sometime next year, because, you know, we don't want, and we will keep the terms cranial diabetes insipidus and nephrogenic diabetes insipidus in parentheses, in other words, in brackets, so that when you're looking online for Medline searches, you can still find this. So this is not a big bang. This is going to be a slow, gradual transition.
Thank you. Next question. Can a head injury or damage to the hypothalamus cause intermittent DI? Can symptoms occur years after the injury?
Yeah, actually, that's a really important question, because post-traumatic hypopituitarism, in other words, physical trauma rather than mental trauma, can certainly interrupt the blood flow from the hypothalamus to the pituitary. And it's quite an underdiagnosed thing, because if people have a big car accident or a head injury, they're going to feel a bit rubbish. They'll go to, so it depends on the individual story. So obviously I don't know your individual case, but absolutely yes. And it's quite underdiagnosed, both anterior and posterior pituitary insufficiency. The anterior hormones are things like growth hormone, hydrocortisone, thyroxine, which many of you will be on. Posterior pituitary is the vasopressin. And so if you're running on empty, it's the equivalent of driving your car when it's on yellow on the petrol. Most of the time you're okay, but when push comes to shove, you're going to break down on the M1. So if you're getting intermittent symptoms of diabetes insipidus, or whatever you want to call it, it probably means you're pushing your body to the limit when you're dehydrated, and then the symptoms are coming out. So you may have a partial deficiency of those hormones that I would recommend is investigated by an endocrinologist, to be honest. So absolutely, head injury can cause that.
Miles, can I ask a question?
Yeah.
Can undiagnosed diabetes insipidus, or maybe some aftermath of having diabetes insipidus, or any which way, can it ever cause temporary sort of paralyzed, like feeling paralyzed? So for example, you're sitting there and you can't move your arms, your legs, everything's heavy, it's tingly, and then can it make your face kind of droop? Can it make you look like you're having a stroke?
Well, I mean, there are many other causes of those symptoms. So, for example, migraine or actual cerebral, so the low calcium. There are loads of things that can cause weird symptoms, but the answer is any change in the brain. If you've got a very low sodium and a swollen brain, it can cause focal neurological symptoms, just like you're having a stroke. So although those symptoms are not classic, yes is the answer. I mean, the way low sodium goes is start off with it doesn't cause any symptoms, and then when the brain swells a bit, you tend to be a bit thick, muddled headed. So people that have, so the way you tell patients with diabetes insipidus if they're on too much of the desmopressin, or if they're drinking too much, they tend to be a bit thick-headed and a bit muddled-headed and a bit headachy and not quite thinking right. And then you go a bit drowsy and get neurological signs. But absolutely, I mean, I saw a patient in hospital a couple of weeks ago who came in with a very low sodium and was slightly over enthusiastically treated with very high sodium content of a drip, and the sodium had gone up from very low to very high, which is quite dangerous actually. In fact, we've just rewritten the guidelines today on what to do with that, and those patients can get a very bad clinical syndrome called osmotic demyelination, where it looks indistinguishable from a stroke. So I don't think that's happening to you, Ashley, but there's no doubt you can get lots of weird neurological symptoms with any change in fluid shift. So I think one would need to spend a bit more time on your particular thing.
We'll touch base. I was admitted into hospital today. They thought I was having a stroke.
Right. Okay. Well,
and it comes bang. You're like paralyzed. Your face drops.
Right.
And then all of a sudden you kind of come round, and this is literally today. And I'm like sitting here going, they can take a blood test and say, have you got this? How have you got that? But actually, is there something else going on here that I'm just not aware of?
I mean, your case, to be honest with you, is a bit of a nightmare because it's quite difficult. So I think the devil is in the detail with you. Juliet is asking about Bell's palsy. That tends not to recover, Juliet, so quickly. And Elle has said, when my sodium was 114, I felt just like that, presumably the muddled headedness and feeling pretty ropey. And Ruth says her as well, when her sodium went to 112. So one of the things we found in this Lancet, we've just published a paper of the over 1,000 patients, is we found that patients who gave themselves 1 day a week where they were a bit late with their desmopressin, where they allowed themselves an unpleasant day, either weeing too much or being thirsty, that was quite a good, and it sort of partly goes into your self-regulating thing, Ashley, that the body can self-regulate. The body's brilliant at offloading stuff when it needs to. If you can give yourself a day a week where you're peeing a bit more and you're a bit thirsty, so you're late or you omit the desmopressin, which is the treatment, then we found in that study that the far fewer patients were admitted with low sodium to hospital. So in other words, there's something to be said for letting it all come out once a week a little bit, which is, obviously do that when you're in a socially acceptable situation, not when you're just about to drive from Land's End to John O'Groats or something. So yeah. Pat,
Miles,
any other things you've noticed from the question?
Just about that breakthrough, having a day breakthrough, can be quite difficult, if people are working or just trying to get on with your life. You'd be chained to the house, the toilet, drinks. So
yeah. No, quite. And in fact, we've got a famous person, Pat Gilroy, who runs Got DI. So she's just said most members of Got DI do a daily breakthrough, or at least several times per week. Once a week may not be enough for some people with DI. So absolutely. I mean, it's one of those, Pat, where and it's great that the other famous DI Pat is here, as well as Pat McBride, Pat McGilroy. So this is a truly global pursuit, because Pat's in America now. I don't know what time of day it is over there, but you have to decide on your priority. Like any chronic disease or chronic condition, you have to decide on what is right for you and what fits in with your life, and how much you want the disease to control and how much you're in control of the disease. But I think certainly being admitted to hospital with a low sodium means you've gone out of control. So we rightly or wrongly, but over 1,034 patients, that those that did what Pat was saying had less admissions to hospital with low sodium.
Or
how you fit that in with your own life.
If you take your dose once you've broken through and you know the symptoms, which can be quite a small window. So if you take your dose then. Now,
Ruth has said it's hard to do breakthroughs when you're a postie. So yeah, I could see that. I could see that. But maybe when you finish your rounds, you're going to have to work that one out, Ruth. I don't know if that's Ruth, but it's Ruth's iPhone. But yeah.
So the next one is, what's the best way to raise sodium levels if I suspect I may have taken too much desmo?
Yeah, that's a really good question. Now, well, first of all, I guess, so it depends on extremes. So I suppose the day-to-day, let's just say you're having a normal day and you think, oh dear, I think I might have taken an extra desmopressin and I might have drunk a bit too much fluid and I'm feeling headachy and I'm not quite right. So in that situation, the right thing to do is to listen to your body, not take any desmopressin, and allow yourself to wee. Okay. And eventually what will happen is you will wee off that fluid, and your sodium will come up to normal. If you're still feeling ropey and you haven't peed, and you still feel like you're in trouble, then I would highly recommend that you spoke to the endocrine team. Don't muck around. Just speak to the hopefully most people have got an endocrine specialist nurse, who are usually the most contactable, because doctors are never bloody contactable. But I think what would happen if you're in doubt, ring the nurse, get a blood sodium check, and take some advice. Now, what we say to the doctors in hospitals, and we've written some acute guidelines for doctors in hospital because none of them know what to do, is that we tell them if someone is admitted to hospital with a low sodium, yes, miss out the desmopressin, but for God's sake, don't cross out the desmopressin completely and throw the baby out with the bathwater, excuse the pun, because you can be guaranteed that the following day, the diabetes insipidus, or the increased urine output, will return, and you will get very, very dehydrated if you don't get desmopressin. So it needs, I tell the junior doctors, it's a bit like Jamie Oliver. You need to, or a bit like the Great British Bake Off, you have to put your buns in the oven or whatever, and you have to go and check what's happening. You check the urine output, you check to see how the patient is, you check what the sodium is, and you react according to that individual patient. You can't practice guideline-driven medicine when each patient is individual with different requirements. So the best thing I can recommend for the person asking the question is to know your own body and have a really good session of education with a nurse, so you know when you're likely to need less or more desmopressin. So the time when you need more desmopressin and more fluids is when you're thirsty and when you're peeing gallons of pale water. And the time when you need less desmopressin and less fluids is when you're feeling a bit thick-headed and you haven't peed for a while. And you just need to calibrate that yourself.
So that really answers the question on what's the correct way to decide on dosage. So thank you.
Yeah, just on that, Pat, on dosage, because this is misunderstood by doctors, let alone nurses, is that the dose that you take by spray is completely different to the dose you take by tablet, which is completely different to the dose you have by injection. So the dose by tablet is in the order of magnitude of 50 to 100 micrograms once, twice, 3 times a day. So 50 to 100 micrograms. The dose of intranasal is 10 micrograms, so 1/10 the dose. And the dose intramuscularly or intravenously is 1 microgram. So it's really important that doctors and pharmacists know the dose. And yeah, the dose titration will be all about upping and downing depending on symptoms.
Okay. Somebody said that they have DI following pituitary surgery, has been on desmo for several months, recently started at a gym, and has found that the effect of their normal desmopressin dose seems to wear off more quickly. Does exercise affect how the body breaks down desmopressin?
Yeah, well, there's a couple of interesting things there. Firstly, pituitary surgery commonly causes transient diabetes insipidus. In other words, when you've got a surgeon noodling around with that part of the brain, it's not surprising that the brain sort of objects a little. And so quite commonly for the first 24 hours after a pituitary operation, people will pee gallons and will need desmopressin because of the physical effect of having a surgeon rummaging around the pituitary gland. And then what tends to happen is patients are weaned off desmopressin and it's temporary. Now, what a good endocrine unit does, and what most good endocrine units will do, is after pituitary surgery, when you've gone home, is they will check your sodium at day 5 to 7, because what often happens, it goes the other way, is the sodium goes low, and that's called the syndrome of inappropriate ADH, which is the opposite, because you're releasing all that hormone, and then it goes low. And then what can happen, believe it or not, is you can go back to having diabetes insipidus again. So it's 1, 2, 3. It's a so-called triphasic response, which is quite unusual. So the answer is, it sounds like if you're 2 months into it and you're needing desmopressin, you probably got permanent diabetes insipidus. And I would suspect you probably had either an unusual pituitary tumor or a pretty major operation. So it may have been a craniopharyngioma. It's obviously difficult to talk to people individually. And then the business about exercise. Well, let's think what's happening when you're exercising. What you're doing is you're losing water through sweat. You're hyperventilating, or you're breathing heavily, so you're losing water through, the equivalent of panting, and so you're becoming dehydrated. So if in the normal situation, if you did not have diabetes insipidus, you are losing water. So there's no doubt that your brain will become dehydrated, and in the normal situation would say two things. Number one, I need to drink, and number two, I need to produce more vasopressin in order to conserve water. But because of your pituitary operation, your brain cannot produce more vasopressin. So what your brain is telling you is, I need to take more desmopressin and I need to drink more fluid. So it absolutely makes sense that when you're doing exercise, you will need more desmopressin. And there's no reason why we should not be able to have elite athletes. I mean, we have elite athletes that have diabetes insipidus. So we just need to sort of work out what the fluid requirements are. But I would strongly recommend making sure you're pre-hydrated before you do any stamina exercise, because of the risk of dehydration, and to replace yourself with the appropriate fluid. So yes, that does make a lot of sense. But talk to your endocrinologist and your nurse for sure. CP said, bingo, it was a craniopharyngioma back in February. Thank you so much.
Miles, are you still happy that people can write down your email address and send you?
Yeah.
Okay. So
yeah,
there's just a few, well, there's quite a few more, so I'll do as many as I can. If I haven't picked up on your query, because we've probably covered some of it, then you can email Miles directly. Should I have regular checkups with an endocrinologist?
It depends if you've got an endocrine problem, but if you've got diabetes insipidus and if you've got pituitary disease, yes, for sure. Please do. And please do not take no for an answer. One thing I would say is it can be quite difficult to initially diagnose diabetes insipidus in patients that do not have pituitary disease. So quite a common symptom is, when you see people going around with a bottle of water, it's quite common that there is a behavioral desire to drink water, and that just exists. It can be linked with psychiatric disease, not always. And so that's called primary polydipsia, which is a behavioral desire to drink. And of course, if you're drinking a lot of water, you're going to pee a lot of water because you're suppressing vasopressin appropriately. You're making sure that the plug is out, so that you don't reabsorb water. But if you have been diagnosed, and Pat, we did a BMJ symposium on how GPs should diagnose diabetes insipidus, and that's probably the topic of a whole separate hour, really. But I'll take it that if you have been diagnosed with confirmed AVP deficiency, AVP resistance, whatever you want to call it, then yes, you should be under an endocrinologist for sure.
Okay. Somebody's saying that Sharon, she's been told that her DI has come about due to having a COVID booster. Have we heard of this happening around here or the world?
Well, that's really interesting. That's very interesting. So we're learning quite a lot from the old COVID. And I had to give a talk at the Royal Society of Medicine last year on sodium and COVID. And it's both not just the COVID, but it's also the COVID vaccination, particularly the AstraZeneca, is causing quite a lot of endocrine pathology. Actually, we've just written a paper showing that the AstraZeneca jab can cause adrenal gland infarction, so hyperadrenalism. So patients that get abdominal pain and low sodium and high potassium a week after their COVID jab need to get their cortisol checked. Certainly, COVID can be associated with shifts in fluid, either low sodium and high sodium. So there is, some patients that had the really early cytokine storm would have a big autoimmune inflammation. So absolutely, it is not beyond the realms of possibility that the coronavirus, either the vaccine or the condition, might have caused a problem with vasopressin regulation. Yeah. I mean, it's not many glands have been affected. Thyroid produces inflammation of the thyroid, so there's absolutely no reason why it shouldn't have caused problems with the pituitary gland, for sure. But there aren't that many case reports. I'd need to have a look at the literature.
Okay. Please, could you recommend the best way to miss desmopressin? Breakthrough when I feel bloated.
Yeah, well, that's where I think you in the audience are the experts. Oh, sorry, when you feel, say that again. Was there a caveat? What was it?
So recommend the best way that she can miss desmopressin or breakthrough. So have a breakthrough when they feel bloated.
Yeah, well, I'm guessing when you feel bloated, that means, yeah, you've got too much water on board. And so that probably is a sign that you need to somehow let it all out. And again, as I was saying, I think in many ways I've got as much to learn from this group as you have from me, because I'd be very interested to see how people do it. And I think Gilroy sounds like she'd be very helpful person to say how her group, but essentially, you know, I don't know. So let's just say don't do it. I guess if you're feeling unwell and you're really worried, you've got a low sodium, you're feeling thick-headed, whatever social engagement you've got, then probably not being admitted with a hyponatremic crisis overrides anything. So you've got to be sensible. But if you think you can do a sort of controlled explosion, as it were, then I guess the thing to do is to maybe, if you're working full time, then you'll need to do it on the weekend, is just miss out let's just say you're on 500, let's just say you're on 3 tablets a day of desmopressin. You wake up in the morning and you've got this thick-headed, you're worried that you're a bit bloated, then miss out the desmopressin that morning and then just see how much you pee that morning. You're going to start peeing. If you don't, wait a bit longer, miss out the lunchtime desmopressin. If you haven't peed, you will start peeing. And then I'm guessing that by the time of the evening, you'll be peeing like a trooper. And if you want a full night's sleep, and as long as you're feeling better in yourself and you started to feel a bit dehydrated, drink according to thirst, and then probably take some desmopressin at night. But do remember that there was a time when desmopressin didn't exist. And the only treatment for diabetes insipidus was fluid replacement. So even if you cannot get hold of desmopressin, you can still keep yourself alive by drinking, okay? So if you're not sure what to do with desmopressin, then rely on your thirst mechanism and on the color of your urine. And you can, if you notice that your urine is too pale and you're peeing too much and you're really thirsty, you need to drink. And if your urine is dark and you're not thirsty, you don't need to drink. If in doubt, ask an endocrinologist.
So we've got 2 more questions. I'm sorry that there's quite a few more than this, but the time is getting on. So Abby has an inflamed pituitary gland and stalk, which has caused DI. She's had further tests, but there was no reason for this happening. Yeah,
so that's really interesting, Abby. So you've got a condition called hypophysitis. So the fancy word for the pituitary is hypophysis, hypophysis. It's the Greek for hanging under the brain, because the pituitary gland hangs under the brain. So you've probably got a condition called lymphocytic hypophysitis, which incidentally, I'm not totally sure that Ashley doesn't have, because that is something that occurs in pregnancy. It's an autoimmune condition. But there are other causes of inflamed pituitary glands. There's a condition called histiocytosis X, neurosarcoidosis. There's something called IgG disease. We wrote a paper a few years ago with my brilliant genius colleague, Trevor Howlett, who's now retired. I went to his 70th birthday a few weeks ago. He's the reason I moved up from London to Leicester, because we've got an amazing database. And we looked at all of our patients with inflammatory hypophysitis like you. And actually, it's not the end of the world if you never find the precise cause. And having a biopsy of that part of the brain can cause major side effects. So what's better is to have a cool endocrinologist that can just observe you, do some scans. I've got one patient who we gave intravenous methylprednisolone steroids, which really helped. Actually, the scan didn't make her feel that much better, but it helped the scan. So yeah, you've probably got a condition called hypophysitis, which will come and go due to autoimmune disease. And you need to listen to your body and have a decent endocrinologist that's going to follow you up. And if you get those symptoms, you need some blood tests and you need a scan, an MRI with gadolinium to look very closely. And actually, in the conferences now, we're beginning to find out about this thing called IgG disease. And there are lots of fancy scans. There's something called a PET scan that some of you may have had. And that's a really good way of looking at disease outside the pituitary gland. Some people get skin rashes, so it'd be worth getting a skin biopsy. So again, the devil is in the detail with the individual patient, but you've got an interesting, rare, but completely treatable disease, actually.
Oh, thank you so much. Thank you.
You're welcome, Abby.
So we've only got 5 minutes left, and obviously I don't want to keep Miles, because he's been on most of this evening, and also Ashley, and I thank them very much for being with us. You can send your questions into Miles via email, which we have put the address on. If you are having trouble doing that, then please do send them to helpline at Pituitary. There's also a section on the ticket tailor to put a query in as well. So don't feel alone with your questions. Please do send them to us.
And just to give a plug, Pat, for you and the Pituitary Foundation, they're amazing. We're really lucky in the UK to have the Pituitary Foundation, because they have a real handle on who to ask around the country. And I've had emails from Pat before, and they really are working on your behalf. If they think around your patch things aren't quite right, they will email us to try and help out. And so we have a lot to thank them for, actually.
Thank you. So to close the session, we would like to thank you all for coming along, and seeing you is great, and all these fellow DI patients. And thank you very much to Miles and to Ashley for joining us and bringing us your experience, Ashley, which, you know, is really gutting, to be honest, and Miles for your expertise. So all of our sessions will be available to watch on YouTube and on our website at a later date. And please, sorry, I can't speak now because I'm thirsty. Please feel free to visit our social media channels and our website to see the other sessions we have available, as well as our resources, of course, at pituitary.org.uk. We are proud to be able to bring you a month's worth of different informative workshops and online sessions for free, but we do rely heavily on the kind donations of supporters. If you found this session useful and are able to do so, please consider donating to the Pituitary Foundation by texting Living Well 10 to 70085 to donate £10. Texts cost £10 plus one standard rate message. And don't forget to have a look at the rest of our Awareness Month programme. And thank you so much. It was really great to have you with us, and see you again soon. Thank you.
Well done, Pat. Thank you very much. Good night, all.
Good night, everybody. Good night.